This is the fourth in the endocrine series of the pancreas. Pancreas has a lot of functions, but today I just want to talk about the endocrine side, give you a little hint on the exocrine side as well. So what we're going to go through is basically the anatomy of the pancreas a little bit, talk about what its overall functions are. And again, I'll do the exocrine side of it in the GI system. We're going to talk about specifically today is glucose regulation, type 1 and type 2 diabetes, some of the complications, some of the pathologies, and a little tiny bit about aging. It's tucked, the pancreas is tucked in behind the ribs, behind the stomach. This is an anatomage, this is visible body imagery, dissecting away the stomach, a lot of the structures so you can see the intensive vascular supply. That's why they call it no man's land. Surgeons hate to operate in this site. If you notice, this is the inferior vena cava and the aorta, and the pancreas is sitting right across all this vascular stuff. Looking further into the microanatomy, it has two different sides. It has the endocrine side and the exocrine side. And the endocrine side that we're going to talk about mostly with type 1 and type 2 diabetes are these islet cells. And notice these capillaries that are coursing through these islet cells. These islets are producing insulin and glucagon. And then on the other side, or within the pancreas as well, is this exocrine side and the acini that are producing bicarbonate and digestive enzymes. And all of that exocrine side gets dumped into these ductworks. As you can see, the ducts coming down here and dumping into the duodenum. Bicarbonate and enzymes are dumped into the duodenum. Where does glucagon and insulin go? Does it go into the duodenum as well, or into the local capillaries? And your answer should be into the local capillaries that takes it into the general bloodstream. So we have two separate systems, this exocrine side and endocrine side. So on the exocrine side, this, for more anatomy, this is the hepatopancreatic duct. When I grew up, it was called the ampulla of Vater. And it's emptying not only the secretions from the pancreas, but also the bile that comes down from the liver and gallbladder. The hormones, of course, are dumped directly into the bloodstream. So here's a case scenario. JC has her gallbladder removed. She's got gallstones. And one of those gallstones had gotten squeezed out of the gallbladder and gotten stuck in this common bile duct. And this is a major problem because it's going to cause bile to back up and cause abdominal pain every time she tries to eat, and the bile can't be secreted into the duodenum to help with digestion. From what you know now about the anatomy of the gallbladder, what is the safest way to remove the gallstone that is now lodged in that common bile duct? Possibility A, open surgery, open laparotomy. Laparotomy is a term for opening the abdomen directly and do a surgical exploration. Your other option is through the duodenum endoscopically, where you're going through the mouth, the stomach, and down into the duodenum, going through this ampulla of Vater and using a basket to retrieve. And the answer is endoscopically. This is an outpatient procedure and a very quick recovery. So endoscopy, in an endoscopy unit, the endoscopist could be a surgeon, gastroenterologist, places the endoscope down. It's got a side port that allows for a little guide to go in here, get a basket, and retrieve the gallstone. Next fun question. Who is missing in this picture? The reason I'm asking you this question is I don't want you to think that anytime you go in to have this kind of procedure, you're in there completely alone, because the answer is all of the above. There will be someone assisting the endoscopist. There's going to be an anesthesiologist or a nurse anesthetist providing medications, and a circulating nurse to help manage and document procedures. And this is an image, actually, I took with my iPhone during one of these endoscopy cases. This is not retrieving a stone, but it's showing the pyloric sphincter at the stomach, at the junction between the stomach and the duodenum. And what you're seeing here is the duodenum, and that's bile. It's kind of come back up. That's the yellow stuff. And this is some more coming down and all the folds of the duodenum. And because of the type of camera on this particular scope, you're not going to see the ampulla of Vater. But it does give you an idea of all the folds and actually how challenging it is and how adept these endoscopists need to be at finding the ampulla of Vater and trying to thread this little catheter to retrieve stones. All right, so now let's go into blood glucose regulation. This is the endocrine side of the pancreas. Unlike the pituitary, no endocrine organ directs the pancreas. So what type of stimulation does it receive? Hormonal, humoral, or neuronal? And the answer is humoral. So the examples of humoral are the pancreas here, but another humoral is things like low serum calcium. It's picked up by the parathyroids to release PTH, or parathyroid hormone. The neuronal examples are stimulation of the adrenal glands. So acute stress sends out these neuronal signals to the adrenal medulla, and you can release epinephrine and norepinephrine. This is happening in acute stress and stimulation of the sympathetic nervous system. A hormone example is the hypothyroid and pituitary axis that stimulates hormones to, for instance, the thyroid gland to release T3 and T4. There's the adrenal gland, adrenal cortex to release cortisol. And this is an example of the testicle. Gonadotropins, LH, FSH, stimulating the testicles to release testosterone. So the humoral triggers are not under the control of the hypothalamus or the nervous system. They're responding to blood levels of glucose in the plasma. So in a hungry state, a fasting state, where you have low blood glucose, your alpha cells in your pancreas release glucagon. In states of high blood sugar, you've just eaten a candy bar, a brownie. Think of beta cells as brownie cells. getting stimulated and releasing insulin. And so they're kind of the yin and the yang to each other. So the state of diabetes is simply diabetes mellitus specifically. Diabetes mellitus is sustained high glucose levels in the plasma. This is a case presentation. A patient I took care of who came to the clinic. He was a 50-year-old man with poorly controlled diabetes and a non-healing toe injury. And these are actually maggots that are growing out, or that are coming out of the end of the toe. So the complications of diabetes, this is a perfect example of a complication. They get nerve damage, and so you don't feel when you have an injury. And there's very poor wound healing because the small vessels get diseased. So high glucose is hard on the nervous system, peripheral nervous system. So true or false, everyone with type 2 diabetes is overweight or obese. The answer is false. This particular patient was not overweight or obese. And that's me, FYI. So the causes, the number one cause is actually central obesity, but you can also see it with increasing age, genetic factors, and autoimmunity. So again, the complications of this chronic elevated blood glucose are the inflammation of small vessels, nerve cells, and this is a gradual but a slower death. Very high glucose, high glucose can develop diabetic ketoacidosis, and that is a quick death. So patients that are in high diabetic ketoacidosis, people that present with acute onset of type 1 diabetes can present with diabetic ketoacidosis, blood sugar levels in the 500s. So to understand the glucose just a little bit better, let's just review metabolism just a tiny bit. Glucose has to get into cells because actually what your energy source is ATP, and glucose is needed to combine with oxygen to produce this energy source ATP, and CO2 is a byproduct. And that's what's going on in all your cells of your body. And that byproduct CO2 has to be released. And so when you take a deep breath, you're taking in oxygen. When you're exhaling, you're releasing the byproduct CO2 from all the metabolism that's going on in your body. So the glucose has to get into the cells. And that's through a transport system. And it takes two steps. It takes the step of having insulin, the hormone insulin that unlocks these receptor sites. And once these unlock the key, then these insulin receptors open up and glucose can enter in the cell. So both are required. This is a little video just showing how blood glucose in the bloodstream gets through into the inside the cells. But it requires that insulin hormone to unlock those receptors, allowing the glucose to enter the cells. Also, there are some enzymes, AMPK and SIRT1, that are required as well. And these two, AMPK specifically, decreases with aging. So in which type of diabetes does the insulin fail to produce insulin at all? type 1 or type 2? Answer is type 1. The other term people use for type 1 is juvenile onset diabetes. There are children now with diabetes, type 2 diabetes. So if you want to stay safe, it's better to use the terminology type 1 and type 2. Type 1 is that no insulin is being, or very, very little insulin is being produced. So they have these receptors, just no insulin. So this is the pancreas, unable to work. These patients require insulin shots, and they are the ones that are at risk for diabetic ketoacidosis. A typical example, or what you'd see in times past, are the juvenile onset diabetes, where something like a viral illness or something has killed off the beta cells. This little blue depiction here, the blue cells, and these are little capillaries. And so they're unable to produce insulin. So no insulin is getting into the bloodstream. Type 2 diabetes, on the other hand, has working pancreatic beta cells. So insulin is being made, but the receptors are resistant to the insulin. So here's a depiction. Here's the receptor sites. They're just not open. The insulin's there, but the receptor sites are not open, and so glucose accumulates in the bloodstream. So basically, the receptor sites are the ones that are out to lunch. And the treatment of this is insulin only if it's severe. Preferably, it's trying to get weight down, but also addressing other things that can increase weight, which is stress, diet, and there's oral medications that can treat type 2 diabetes. How does stress lead to insulin resistance in type 2 diabetes? A, stimulates the appetite. B, visceral fat deposition. That's fat around the visceral organs, like around the heart, the liver, the intestines, the GI tract. Disrupting sleep. Or D, all is correct. Answer is all of that is correct. Stress, chronic stress, the worry type of stress is particularly hard on the receptors. Because what happens is it causes this release of cortisol, and increased cortisol increases sugar and fat intake, increases appetite, and it increases deposition preferentially to the abdominal viscera. And so it becomes this cycle. Insulin resistance, abdominal obesity, it's this chronic cycle of increasing insulin resistance and fat and increased weight. So elevated cortisol can be from chronic stress, diseases. So you can have a tumor, adrenal tumors, or it can be caused by medications. So if you're taking, for instance, prednisone, it increases the cortisol. So all of these things increase insulin resistance. So disease presentation. This is a 43-year-old man with severe asthma and allergies. He's placed on high-dose prednisone. 4 months later, he's gained a lot of weight, and you can start seeing these stretch marks. These are called abdominal stria. That's from stretching so fast, the skin stretching so fast that you get these marks. It presents with all these things: weight gain, hypertension, abdominal stria, and elevated blood sugar. The syndrome of having persistent high cortisol levels, specifically induced by either a tumor or high dose prednisone. It's called Cushing syndrome. And the symptoms of Cushing syndrome, or very high cortisol levels, are all the things we talk about in type 2 diabetes and central obesity: vascular disease, fatty liver disease, heart disease, infections, and also notice depression. Okay, so as a review, what body shape is a precursor to insulin resistance in type 2 diabetes? The apple or the pear? Basically, it's the apple. So central obesity increases risk for type 2 diabetes because deposition of adipose tissue around the viscera are metabolically active. So the adipose cells, as they accumulate, as they get larger and larger, they actually outgrow their blood supply. And so there's some death of cells within the center of these fat depositions. The macrophages come in to clean up the dead tissue, the necrotic, old and dying cells. And then the byproducts of the macrophages, the debris, starts this inflammatory response. And that eventually results in this injury, the blood vessel lining, insulin resistance, and increased fat or lipolysis, breakdown of fat. So treatment, type 2 diabetes, weight loss, reduce cortisol levels. So check the medications patients are on, use alternate ways of reducing cortisol levels, and using metformin as a medication. There's some also medications that could be used. One of the medications is metformin, a very old medication. It's been 70 years out on the market. So the answer, all are correct. Now I want to take a moment to talk about metformin. There's a lot of other medications that are out there that are newer, but metformin is particularly interesting. It's been studied for many, many years. And the way it works is several factors. It not only improves insulin receptor sensitivity, but it actually has all these other really curious actions that they've been noticing. Mice that have been on metformin for a long period of time compared to the cohorts actually live longer. They notice also an improved immunity. Interesting, metformin does not increase insulin levels in the bloodstream, does not stimulate beta cells to produce insulin. So it doesn't treat type 1 diabetes. It just improves receptor sites. So you can take metformin without reducing blood sugar. Just for an FYI, for your interest, with all the COVID-19, there was a concern about patients that are a higher risk for mortality from COVID-19. They noticed that patients, women, they did a study with women on type 2 diabetes that were on metformin. And if they had been taking metformin for a minimum of 60 days before they got a COVID-19 infection, they had a significant reduction in mortality as compared to their cohorts. The other next question, let's ask this questions first. The enzyme AMPK and SIRT1 aid in glucose transport at the receptor site. Can you guess what happens with aging? And I mentioned this, let's check short-term memory. With aging, do you get reduced levels of AMPK, insulin receptor resistance, and type 2 diabetes? The answer, aging causes all of this. So David Sinclair is a lifespan researcher, and he's published a great deal in peer-reviewed journals, and this is a book that's very understandable for the lay public. And he not only looked at metformin, but some of the other factors. Come back here. Okay. So metformin, what they found is improves insulin signaling, improves the microbiome of the gut, so it affects a lot of other factors as well. So to go over just a few more slides, in summary, we've talked about the anatomy of the pancreas, where this pancreas resides. Oh, I keep touching that. The pancreatic functions, endocrine and exocrine functions, the two types of glucose regulation diseases, type 1, type 2, and the enzymatic function, which I'll talk about in the GI. So last couple questions. What type of diabetes must be treated with insulin, type 1 or type 2? And the answer is type 1. In summary, the type 1, no insulin is being produced. These are the juvenile onset, but you can also completely destroy your beta cells with alcohol. So that is not juvenile onset, but those patients present very thin, malnourished, and they've lost their endocrine side and their exocrine side of their pancreas. We'll talk about that in the GI system. In type 2 diabetes, insulin is produced, but there's a receptor site dysfunction caused from either genetics, obesity, stress, aging. So just a little quote, people say, nothing is impossible, but I do nothing every day. My dog. You'll probably hear the dog move around in the background from time to time. So questions, please leave in the comment section, and please